Hello everyone, and thank you for joining us to today's Wednesday webinar. I'm going to start just with small housekeeping and very important. I'd like to begin by acknowledging the traditional owners of the land on which we meet today, wherever you are, virtually and everywhere else. And I'd also like to pay my respect to elders past and present. Now on to the webinar. So I'm very pleased to introduce Vanessa Nube on offloading and what does this mean in practice, and I'm going to hand over to her to take it away. So excuse me. Oh, I will interrupt one moment. In the chat, any questions for the end of the program, just pop your questions in there, hit the little Q button, and I'll ask the questions at the end. So keep them going throughout the presentation and we'll make sure that everyone has their say or gets any pearls of wisdom. Vanessa, please take it away.
Thanks, Georgie, and thanks to the NADC and FootForward team for putting this topic on and asking me to speak today. Firstly, I guess important thing to say is that this is an essential part of treating diabetes-related foot ulcers, partly because we walk around on our feet and they need to be protected from injury to enable them to heal, but also because most of the diabetes-related foot ulcers that we treat are related to a loss of sensation. So patients have neuropathy and they need some external form of device to protect their foot because they would otherwise continue to walk on it. Now, Georgia, I forgot to ask you, will these slides progress or will I need to press a button? There we go, next. Sorry, I just realised. So when we're talking about offloading, we first have to think about whether we're doing this really prevention or treatment. I'm going to cover both those topics just a little bit today in the short time we have. But we're thinking about these types of feet here and these types of lesions so that we can make sure that we've done all we can to allow those tissues to either heal or to prevent them from breaking down in the first place. So if you look at the picture on the left, you can see some really clawed toes there. Now, those are the sort of things that we want to be picking up when we're assessing the foot in the first instance, even in that annual foot screen that we should all be doing on our patients with diabetes. You want to be picking up on the fact that a patient may have those sort of clawed toes because they're not going to fit into a regular footwear without there causing trauma. And if you do get a wound on one of those toes, they can progress very quickly to being quite severe infections. So you need to be thinking about those. The next picture along, probably not quite as obvious, but that person doesn't really bear much weight on their heel. They've got quite a C-shaped foot and a prominence on the plantar lateral aspect. And so that would need to be carefully protected as well. The middle one and the next one along are both plantar calluses on the hallux and on the forefoot. And the podiatrist would understand the mechanical reasons why those areas are taking an increased load. But these are the sort of calluses we shouldn't ignore. They indicate a higher area of pressure, and those types of lesions are pre-ulcerous in someone who's got a loss of protective sensation. But it's also worth bearing in mind that we have a lot of patients out there who have iatrogenic foot deformity, such as this person here who's had quite a proximal amputation, and that person's going to need some very careful consideration as to how to protect that foot lifelong. So as I said, there's some key considerations there in terms of treatment and prevention, but in terms of how we cover this topic today, I want you to think about your scope of practice, thinking about what you bring to the table in terms of your experience and knowledge, and also the patient's experiences and preferences, together with bringing together the best evidence to treat our patients. Remember that we have a growing number of accredited high-risk foot services nationally now who are being accredited with the National Association of Diabetes Centres, so you can call on those services to support the management of your patient. But if you don't have access to a high-risk foot service, do remember that we've got podiatrists, orthotists, and also podorthists who are very skilled in assessing and treating patients with this type of treatments. So getting into a little bit more detail, it's important we understand the patient's foot and the patient when we're thinking about how to protect the foot from trauma and pressure and to implement offloading. So first and foremost, you've got neuropathy as an intrinsic factor there. Most of the patients with foot ulcers will have a degree of loss of protective sensation. And neuropathy per se will impact on how a person walks and the pressure under their feet. So people with neuropathy will walk differently, and they often walk quite heavily, increasing the pressures just from the loss of sensation alone. Bony deformities are common in the general population. If they have callus on them, that indicates that there's a very focal area of pressure, and that is a preulcerous area, as we saw in those previous pictures. But more broadly, stepping back, large sort of differences in foot shape, whether a foot is kind of rolled in and flatter, pes planus, or more rolled out and high arched, this will impact on where the pressures are and how we approach the treatment of that foot. As we get older, we lose fatty padding under our feet, and certainly that can make the bony prominences that otherwise were there more important to protect. And we know that as we get older, we lose joint mobility anyway in many cases, but our people with diabetes will have a loss of joint movement sometimes through the glycosylation of collagen, and so those joints can be quite stiff and not as amenable to change with orthotics and things like that, that other patients have more mobility and more joint mobility that is to play with. Certainly, patients will have different activity levels, of course, but gait, balance and strength and overall mechanics will play a part. A lot of people have poor balance, and we have to remember that the effects of neuropathy can be quite proximal as well, and causing quite significant loss of strength and power in the lower limb. Patients' occupations can sometimes present a barrier to using different offloading if they have to wear particular types of footwear or stand. And our patients have other responsibilities outside of work to family and in carer roles themselves in some instances, which really can impact on our decisions. People's weight, and when you're first assessing that patient each year and you're having a look at their feet, have a look at the suitability of their footwear, because that interplay between the foot shape and the footwear will often indicate whether or not that person's at risk of that area of tissue breaking down or not. Overall, the keys to success with pressure offloading are that the device that you choose needs to be effective in offloading the foot. The device per se needs to work. And it may seem like a complete motherhood statement, it is, the patient has to wear the device. And this is where a lot of the problems occur, and a lot of the barriers to success is that we have an issue in that the patients can't feel their feet, and our patients have lives and things that they want to do and not wear the device. So it's important we choose something that is in line with what the patient can and will wear, because it's not going to help or offload anyone's foot if it's in the cupboard. Overall, all patients with diabetes-related foot ulcers need to get off their feet to some extent and reduce their activity. We can't expect people to heal if they continue to ambulate as they did pre-ulcer. So there's always going to be an element of overall reduction in weight-bearing activity that's needed. So what is the best evidence for pressure offloading in these patients when they have got a foot ulcer? Well, the International Working Group guidelines published last year give some very excellent précis of the literature in this area, and they're well worth a read and be quite familiar with them if you're working in this space. But really the high-level recommendations are that the traditional total contact cast, which is a specially moulded and padded cast that goes on up to the knee, can be used very effectively. But the knee-high devices, which are removable, if you make them irremovable, and this has been written up and commonly referred to as an instant total contact cast, both these devices together will produce quite effective redistribution of plantar forces, particularly under the forefoot and the midfoot areas. So they're very effective for those type of wounds. They probably reduce shear because they hold the foot quite stable, and they do reduce the peaks in pressure that occur during gait at heel strike and when the foot passes forward over the forefoot, weight passes over the forefoot. If they're made irremovable, and the total contact casts and the ITCC are, they really force the patient to wear it. They force adherence, and they do reduce people's activity. And in this way, they have produced the most effective offloading and healing outcomes that have been measured. When you're using a knee-high removable or irremovable device, you can put an insole in it, and it's recommended that whether you're using a moulded or non-moulded, that you combine the cushioning and accommodative materials to create an insole and a footbed, which will take up the shape of the sole of the foot. And in that way, it works in a very similar way to the cast. Patient selection is really key with both these therapies. You need to have someone who can walk safely in it, and that does pose a problem for a lot of people, and is a reason why they're probably not more widely used. And that is because quite a few people in this patient group are at high risk of falls. So people's work and other activities may also prevent them from being able to use it, so that needs to be factored in. People can't drive wearing these devices, and in many workplaces they wouldn't be able to stand safely. You'd need to choose a patient who is going to keep their appointments and is going to be able to keep this device dry. There is a small risk of iatrogenic ulceration, because remembering that these patients can't feel, if you're going to leave a device on for an extended period of time, you need to know that they're going to be sensible with it and have the capacity to keep it dry and make those regular appointments for checks. It's not recommended that you use these devices and enclose the foot for long periods of time if there's concurrent infection or peripheral arterial disease. And the guidance on this is fairly clear. So unless you've got neither of those factors, or they're mild and controlled, you really do need to be able to step down to using the knee-high device, but keep it removable so that the foot can be checked on a daily basis and reviewed, so that things like infection and ischemia are more carefully monitored. So stepping down a little, we will find that because of all those reasons that we discussed, there will be quite a few patients who won't be able to wear or safely use a knee-high device. And that's where a lot of these other devices, for which we have slightly less evidence for, but are widely used by experienced clinicians with good success. This is where these start to come into play. And I should say also, these things don't always happen in a mutually exclusive way. Sometimes someone's using a removable cast walker for the majority of the time, but may use these other devices in addition to them when they're not wearing it, or in conjunction with them. So over on the left, you've got just a couple of examples of healing sandals, or what might be termed post-operative shoes. There's quite a broad range of them on the market, and they all have their different attributes. But essentially, they provide enough space within the shoe for the foot to be accommodated, and for there to be placed a temporary insole. Now, what happens with these temporary insoles is that the best way to do them is to combine materials that take up the shape of the foot, but also provide cushioning. And there's an example there of a product called Poron being compressed. You do need to use quite thick layers of Poron. This is not something we're talking about for a couple of millimetres thick here. There's a picture there of a metatarsal dome. Now, these can be used in conjunction with the other devices to specifically offload those metatarsal heads a little bit more. And an example of quite a commonly used therapy there, the white material you can see is a 10 millimetre semi-compressed felt, actually adhered to the person's foot with a small aperture, well shaped and beveled to accommodate for a small plantar neuropathic ulcer. And there's some toe props there as well, of which there are a plethora of different types that podiatrists chiefly use in offloading specific toes when they're a problem. Thinking about heel ulcers probably have the poorest prognosis in terms of location, and that's because they're terribly difficult to offload. And the knee-high devices, whether it be the removable, irremovable, or the total contact cast, don't tend to offload to the same extent at the heel location. They're still recommended for use in terms of the knee-high removable cast walkers, but just bear in mind that they don't work quite as well. And therefore, it's even more important that the patient's amount of walking be drastically reduced. And if you've got a significant plantar heel ulcer, I would seriously consider placing the patient or encouraging them to use a wheelchair, or one of those knee scooters that are sometimes used post-operatively to enable you to have complete non-weight bearing. And when they do have to weight bear or transfer, we tend to use a lot of cushioning in one of those ankle-high devices. So just a few practice tips, just in the time we have around using offloading, and I may have already mentioned some of these, is that, of course, we're going to be assessing the patient quite holistically and working together with the patient on that assessment and determining what the right device is. If you're using felt or foam paddings, they do have to be quite thick. In a patient before they ulcerate, you can get away with using a slightly thinner type of deflection or orthotic device to accommodate the foot shape and try to relieve pressure areas. But once a patient has a foot ulcer, to get the type of offloading that you need, we're talking about very thick padding, so 7 millimeters plus, and combining the firm offloading, if you're doing a deflection, for instance, felt, with cushioning, will help to mitigate some of the potential risks of using those firm devices, such as the edge effect. You need to be replacing things quite often. So felt will compress over a period of 3 to 4 days and reduce in its capacity to offload quite dramatically in that time. So pragmatically, most people would replace that weekly in practice. And even when it comes to foot orthoses, you're really talking about something that needs to be replaced over a period of weeks, if not months, but certainly not years. Any treatment that you're using needs to be assessed for the effect, and this is no different. Objectively measuring the wound size from week to week with an expectation that you will get a gradual reduction in wound size is important, and you need to make sure that you're putting those objective measures in place. When you've first prescribed the offloading, we need to look carefully at the effect of the person standing in it and testing it out as best we can. If you have access to an in-shoe pressure measure system and you're that clever, you can certainly use that, and that will certainly be a wonderful adjunct to your therapy in terms of ensuring straight away whether or not you're getting the offloading that you need. And don't forget our patient education. Universal precautions for low health literacy is what we need to apply here, making sure that our patients have the opportunity to really understand why they need to wear a device and how to use it safely is the best way that we're going to work together with the adherence that's needed to get the outcomes. And it's never over. Once the patient's healed, you really need to think about lifelong foot protection, including pressure offloading the area once it's healed. So getting onto that pressure offloading for lifelong in a minute, I just wanted to say there are a few other things that need to happen to try and reduce the amount of time that people spend on their feet, and that is helping people to do other things in their life, whether it's with family support, meals on wheels, time off work, whatever else is needed to try and get that person to reduce the number of steps they take each day. That's a picture of a corridor outside a foot clinic where you can see all the range of devices that people use to get in and out of the hospital visit. They may not use those around the house, but it means that they're using other things like wheelchairs and knee scooters when they have to travel long distances otherwise on their feet. So in terms of that primary prevention of a pressure area, like we saw at the beginning, and preventing ulcers from coming back, the real common sense approach to footwear is there. All footwear has the capacity to injure the foot, cause ulcers, but it also has the capacity to protect if it's the correct type of shoe. So talking about shoes that get fitted professionally, are wide and deep enough, especially around the toes. So you fit to the longest toe and probably a thumb width or a centimetre longer than the longest toe when the patient is sitting, and making sure that when the patient is standing, the toe's still not on the end. Fastening of footwear is really important to prevent the foot from slipping forward, and this is something a lot of people get wrong, is they'll wear something which is cushioned and well fitted, but as it loosens up with time, the foot just slides forward to the end before it gets tight at the end. All shoes need to be have some form of cushioning, worn with socks, and worn in gradually. Most of us would have experienced a blister at some time from a new shoe. Well, that blister in someone with a loss of sensation or a peripheral arterial disease is the next ulcer. So wearing shoes in gradually with regular inspection of the skin to make sure that the footwear isn't causing an injury is important. And check footwear regularly for wear and tear. It gets a little bit more interesting if the person has an abnormal foot shape or foot deformity. This is when the medical grade footwear comes into play. So patients who have a loss of sensation or peripheral arterial disease and some degree of foot deformity should certainly be considered for referring on for medical grade footwear. These can be off the shelf or they can be custom made. All of them tend to have an extra depth to accommodate the foot and a custom orthoses to address any specific pressure areas. They can be modified or custom made, as I said, and common things that you can apply in a medical grade shoe that you can't in a regular shoe so much are things like rocker soles, which will effectively offload the forefoot area. But of course, like everything else, they're only effective when they're worn most of the time. So patients really need to understand, and you need to make sure that patients are willing to wear them before you set out on the path ahead. They are a high-cost item, and there is government assistance in terms of the funding, but it's a very complex field. And so drawing on the expertise of people who do this often is quite important to help your patients access the financial support that they might need to cover the cost of these devices. So NDIS, aged care are relatively new players in this area. It's really important that patients themselves understand that this needs to be included in their plan if they need them. But we also have a variety of state-based schemes, and our Aboriginal patients are protected through the Chronic Care Supplementary Scheme, which helps them to access things they need to keep them healthy. So in summary, you might be grateful we're coming to the end before any questions. Offloading is required to heal foot ulcers. I didn't mention earlier that there are, of course, other locations in the foot other than the plantar aspect, which still need a degree of protection, even though we've mainly focused on the plantar foot ulcers today. You need to use the best evidence. You can easily find the International Working Group guidelines. They're very helpful, but there is a link there as well. These treatments need to be individualised to the patient. I beg your pardon. Use the professionals with the knowledge and expertise to implement the offloading. If that means using your local health high-risk foot service or engaging a podiatrist with some experience and expertise, remember that there are a range of professionals there to support patients with this part of their treatment. And it's lifelong. Offloading's treating a foot ulcer, but it's also preventing the foot ulcer. It's about lifelong foot protection.
Thank you very much, Vanessa. That was wonderful. And we've got quite a few really great questions. So I'm going to launch right into it. So we're going to start with Delia. And she's asked this isn't often a question, but how often do you monitor patients wearing total contact casts?
Yeah, it is a good question. And I think that it probably depends a little bit on the patient and your service. When we've got an active wound, I think weekly is probably a good idea, but certainly there is that capacity sometimes to use a total contact cast that's bivalve to allow health professionals to take it off and inspect even more often than that, but perhaps weekly is a guide.
I agree. And I suppose there's also, you've got to be aware that swelling and all those things start coming down, and if there's infection, you tend to be a little bit more careful. Jackie asked, is it illegal to drive with these devices on?
Absolutely, and quite dangerous to do so. And I'd urge you to all include that in your education of your patients, both verbal and written. And so when we talk about universal precautions, I think that making sure that we get understanding from our patients about the reason why they have to wear the device to provide some benefit, but also the safety aspect to themselves and others. And when we're using written handouts, I definitely include that on it.
And I think one thing, I mean, I've got a full disclosure, I work with Vanessa. So I think
I've never met you before in my life.
Crazy. I suppose we also do quite a lot of, trying to set up support structures, so for elderly people to get around. And I think when you mentioned, linking into social work and those sorts of things is really important, and family structures just to get around. Otherwise, people are very isolated. So Delia's also got, so which offloading do you recommend for Sharko's feet? And I'd probably say acute and then chronic. So so someone who's in remission versus someone who's nice and acute, still active.
So the treatment for acute Charcot arthropathy is a total contact cast. You need to treat those fractures, and that is the right way to treat an acute fracture. Look, there are always those cases on the side where someone might present subacute, who you might use a removable cast walker with an orthotic device, but the treatment per se is a total contact cast. But oftentimes the treatment can be stepped down depending on where the patient is with their healing, and that might be where those other devices can be helpful, but you need something that's going to pass the ankle and brace the ankle. Once you're in the chronic stage and the fractures have healed and the foot has calmed and been cool for a while, you're transitioning into medical grade footwear and orthoses. And usually that process takes a long time. So you might commence that, and this is a really tricky area. You might commence that work towards the orthoses and footwear as you know, the end of treatment is approaching. So timing is critical. Monitoring is very important, but certainly if a person is going into medical grade footwear and orthoses, they need to be kind of ready to go. You can't have a gap of someone just flopping around in a post-op shoe once they come out of a cast. The other thing to think of, and we didn't talk about this, it's probably a topic you might want to take up in future, is the surgical offloading. So quite a few people, if they weren't caught in time with their acute Charcot's arthropathy, will be left with quite significant deformity. Sometimes you can accommodate that really effectively and keep people offloaded in the footwear, but sometimes they do need to have surgical resection of bony prominences and reconstruction. So that's where surgical offloading can come into it. I would say, in our experience, Georgie, wouldn't you say that sometimes people do really well with medical grade footwear and orthoses for a while, but as they get older, they can actually get a loss of the fat pad, and sometimes they end up having surgery a little bit late as well. So you really need to keep monitoring these people really, really closely.
And it's neuropathy. They can't feel it, and so it does happen unless you're keeping an eye on it. And I suppose this segues into surgical offloading for wounds. So when do you sort of go on to, and you know, referring on to get that surgical opinion?
Look, sometimes we get it quite early because we, when you work, oh, something's falling down. When you see these patients all the time, you get a sense of what you can, you can't offload. So sometimes you're left with a really significant foot deformity, and it might break down, and you're really looking quite early on at what the surgical options might be, and planning for that from the beginning. But I would say the best timing for the surgery is when the patient hasn't got a wound. So that requires some careful work. Sometimes we have someone who we know isn't going to manage that bony prominence well, lifelong, and they need to have some surgery to correct the deformity. And we might use some really rigorous form of offloading in the short term, get them healed, window of opportunity for surgery, and then try and keep them healed in that way. But the best time for having the surgery is when it's not actually ulcerated. They have much less risk of post-operative complications.
Denise has asked, so often it's difficult to access immediate care for a person in isolated areas who has a foot ulcer. What's the best first aid treatment if there's a time delay before they can access a podiatrist or a high-risk foot service?
So look, I think the trusty ankle high post-operative shoes can create a situation where you can put the dressing, you can have a foot safely accommodated. There's no source of trauma from the footwear that they've come out of, and a lot of cushioning can be put in that. And when I say cushioning, I don't mean the dressings. I mean like a thick layer of pour-on, some plastizote. There are over-the-counter devices in terms of the insoles which can create a certain amount of pressure offloading. So you don't necessarily need to customize it, you just need to cushion it a lot with pour-on and plastizote and put it in a post-op shoe. And most patients will find them quite acceptable, so they will leave it on their foot. And then, as you say, you can have a little bit of a window of opportunity then to escalate that patient to more specialist care.
Do you ever prescribe crutches or wheelchairs, or do you have a preference?
If someone can go into a wheelchair, that's fantastic. If someone can go into a wheelchair, they've got no pressure on their foot, and they'll probably heal up quite quickly. Crutches tend not to work. Usually if a person's using crutches, they're carrying them around, they're not using them. And that's just because of the nature of the balance and the loss of sensation that's really required to use them effectively. So I'm sure someone somewhere has found them effective, but in my practice, we haven't. A wheelchair would be great. And just generally staying off the foot, knowing that they should not go to work and try and pull back from other responsibilities as much as possible. Patients who've experienced foot ulcers before will say this. They learn eventually that, a lot of them, that if they can just pause their life and get off their foot for a few days, most injuries will heal quite quickly.
Yeah, good first aid. Paula said, what sort of compensation do you recommend for the foot that's not being offloaded?
Yeah, I got great questions. So so there is a device called a Even Up. There might be other ones as well that I don't know of, but that's something that you can fix onto the bottom of the other shoe to try and equalize the height if you've got them in quite a chunky cast or knee-high device. So that can work. But certainly it's good practice to keep an eye on that other foot and make sure that it's wearing the kind of safe footwear. Assuming that the other foot doesn't have a deformity, we're really talking about that common sense approach that we mentioned in the slides earlier. Lace up, cushioning, wide and deep. So it's safe shoe on the other side, and always check that other foot whenever the patient comes in.
Yeah, always take off both shoes. I've had that drummed into me since I first started. We've also, this is a nice one. So Joanna's asked, what's your opinion on applying adhesive offloading felt directly to the foot, as in one of the previous photos?
So look, we did a little study on this 100 years ago, and we looked at the healing outcomes when we put it directly on the skin or whether we put it in a post-op shoe. And I will say that this felt deflective padding as a treatment, it's really only effective for quite small wounds. It can work well, but you don't use it for large wounds. So, excuse me, just centimetre or so. And that's the type of wounds we used it on. And we didn't find a difference. And I would say that it really comes down to the patient. I don't put it on the skin very often, but for some people who will take a few steps here and there without their device, whose skin integrity is good, I sometimes will put it on the skin. Or other times would be if it's a really small area and I want to make sure that I'm getting it really accurate. Again, if the skin integrity can tolerate it, I will stick it straight on the skin, replacing it every few days. And you can use some of those good products to help protect the skin. Georgie, what are we talking here? Avalon's a brand, probably not supposed to mean brands, but there's probably some skin prep things that you can use under the skin to try and protect them as well. But probably 8 times out of 10, I'm putting it inside the removal cast walker, inside the healing sandal.
And you tend to use Tegaderm and lipstick and get someone to walk beforehand in the shoe, so you know where to apply the felt and those.
Yeah, it's really easy. It's really easy to get it wrong. Actually, you think you know where the pressure is, but you do need to objectively do that. So thanks, Georgie. If you didn't pick up on that technique, yes, you can put a film over the wound, put a bit of lipstick on the outside of that, have the patient stand in, say, their shoe that you're going to put them in, and then you'll get a direct transfer and you can use that. Still do it again with the patient walking because it does seem to move around.
And then there's always the tricks like beveling and making sure you're quite close to the wound.
Yeah, so, probably about 5 millimetres or so away from the wound. Make sure the edges are well beveled back and smoothed, and use it in combination with some cushioning as well, because that'll dampen any edge effect that you might get. And by edge effect, they just mean there's a little bit of increased local pressure that happens where the aperture is, where the edge of the felt is. Just excuse me, I just got to powder my nose. Excuse me, I just got to powder my nose.
I think that's good. Robert's just popped in a question which we've already answered, so I can take it away. Wearing cam boots and Darkos, is it illegal? Yes, and most people don't have, their insurance won't cover them if they have a car accident. And then you couple it with they're having neuropathy, so they can't feel their foot and they've got a very wide boot. So in most states, that's a problem. Our patients who do still drive usually will do a swap, which we warn them of all the problems of doing walking, and if they're only doing it for a short period. But yeah, it's education and empowering people. Angela's asked, suggestions for decreasing weight bearing when patients, other healthcare professionals and specialists are advising patients to exercise.
Yeah, it's a hard one, isn't it? And so, yeah, I probably just do the same things that you do, and that is to reassure people that, yes, that maintaining exercise is really important, and they're absolutely right. But if they could put it on pause, just so that they can heal their foot first, so then they can go back to maintaining a healthy lifestyle, and just make sure that we're all on the same team here. We're all actually agree with you. It's just that it's something that you need to pause for now, so that they don't feel as if they're the meat in the sandwich there, and keeping their communication going. So it's quite hard work that when you're the one who's sending all the letters out and you're just getting verbal back, but making sure that's in the care plan for the patient, and communicating that between other professionals who are involved in the patient's care. That's sometimes where I think working within a team really helps, because you will get on the same page with that treatment plan, but when we're all spread out, that is more challenging. But patient care plan, and just agreeing, but it's temporary.
And also I think in the past we've also used exercise physiologists and done a bit of that upper body weight training. So you're not totally taking it away, you just redirect it.
Yeah, thank you.
Munrit asks, offloading post an ulcer is healed. Do you recommend the use of supportive footwear plus or minus offloading devices most of the duration of the day? So indoors and outdoors, inside and outside.
Yeah, it's one of my my favourite pop quiz questions that I like to check in with patients, because they commonly misunderstand when to use offloading, because a lot of people will put on a shoe formally when they go out of the house, but then put on slippers or nothing around the house, and so they think that applies to their offloading. So it's a really good point that you're raising, and I think there is certainly a need to consider a secondary footwear for around the home for those people who don't necessarily need to wear their more rigorous medical grade footwear 100% of the time. Perhaps you can negotiate 20% of the time is in a slipper, but it's a safe slipper. I don't know if that answers your question, but people do need to be educated that their foot is in contact with the ground and experiencing the same pressures, irrespective of whether they're inside or outside of the house.
We've had some good comments of other people who, so Gaynors, they use as an exercise physiologist for when patients are in TCC to input with.
Yeah, that's excellent.
Yep, and look, we've found them great too. Melanie's said the same thing: chair-based activity, weights and resistance bands, and EPs.
Right.
Yeah. EPs are definitely helpful, and physios as well. So if you've got, it depends on what's available, and having that really clear communication line, don't you think, Vanessa? It's that making sure we're all on the same page.
Yeah, really good points.
Denise, what is a post-op shoe? I'm not aware of the type of shoe this is. I've never seen one.
So, yeah, sorry for the relaxed kind of language on that. That's what we kind of get used to calling them. But there are a range of healing sandals that you can get through orthopedic suppliers. And if you talk with perhaps a podiatrist that or a high-risk foot service near you, they might give you tips on their favourites. We all have, our preferred ones, but there's quite a lot of good products on the market. Quality based on will vary depending on how much you can spend. They start at about $25 and go up from there. Certainly the more you spend, you usually get a more stable device, but they're not the kind of fabric devices that you put on the end of a cast traditionally. There's a little bit more to them. They're covered in at the heel. They usually Velcro over at the middle of the foot. They tend to be quite generic in sizing, and they're used best, I think, when you have the capacity to put some plasters out and pour on and insoles inside them. But yeah, they're different types of healing sandals. If you go to a podiatry supply, you'll see there's a whole range around. Opal produce quite a lot. Sorry to chuck names in as well, and perhaps some of the other people who are listening in can throw up their favourites.
Yeah, I look, it's worth Googling Darko healing shoe, or
okay.
Just say it. So there are quite a few, and I can pop some, if you email me just at projectofficer@FootForward, I'm more than happy to pop you through and give you a little bit more information if you'd like it, because I think we've come to our end. You have done a beautiful presentation and we've had some really wonderful questions.
Yeah, some great contributions.
Absolutely wonderful contributions. So thank you very much. Thank you, Vanessa, and thank you for everyone who's been joining us. Oh yeah, Lisa said Brigitte Medical, lots of really great companies.
Yep.
So thank you very much, everyone, and thank you, Vanessa. We'll say goodbye now.
Bye.